Hi, Dr. Randy Grill, and this is part 2 of dentist hiring video. You must understand the first one and have watched the first one to understand the teeny subculture we're in and the magnitude of change that a dentist has to make. Not all of you are going to make the change. Some of you are just too darn anal to do it. You've done it one way, you were taught this way. You can't go to the dental schools and have them understand what you're doing. You must connect the dots, and only you, doctor, must know your patients. If you do not have a PAS, a patient assessment system like the EMTs do when they answer an emergency call, you're in real trouble. I do an initial AO. Now, when you're an EMT, and I've had some of that training, it's alert and oriented, AO. For nursing homes, I make it very specific. It's awake and oriented. Alertness may never be there, even though, so we call it awake. And so you need to know awake and oriented, frail, medically complex, functionally dependent, 95-year-old female in wheelchair or in walker. We would not think of touching a patient without doing an SpO2 or PR. They are so wrapped up in blankets and their arms are so fragile, even a blood pressure cuff can tear their tissue. What do you think your dentures are going to do in their mouth? Or taking x-rays, and we do have an x-ray machine and self-developing x-rays, which are now very diagnostic. Implant dentists use this same system, but my patients rarely can handle x-rays. If I take a couple x-rays a week, I'm probably taking too many because they're stiff jaws, you have them open, it hurts their jaw, it cuts their tissue because their mouths are like their arms. I always look at arms and legs, even if they're bundled up, to see how purple and cut they are. Corners of their mouth, if you force them open, even doing a filling, you're going to tear the corners. Or if you tear the inside of their mouth, it may not heal up. These are frail, medically complex people with multiple morbidities, just not comorbidities. In other words, you have probably never seen multiple morbidities in your whole life unless you were an oral surgeon. And what happens, just like I had a nursing home, it was a surgical tooth, not safe to remove. I can do mobile teeth. With or without x-rays, depending on what they can do and how infected it is and how important it is to get out and the risk reward in having the POA be on board, that at minimal, every time I take out a tooth on my patients in the nursing home, it could easily trigger a major decline. The number of people I see that go out that were forced to send out because infection may be leaking into their system. And oftentimes I can't get x-rays, and I do percussion and pink gums and say, I do not suspect infection is leaking, but could not confirm with x-rays. I'm all the time saying x-rays impossible, or if I can take them, I do. But it is your documentation that determines if I have somebody in trouble and they need sleep dentistry, and sleep dentistry is going to kill them, or it's going to, I'm sorry, being dramatic, if extractions could trigger terminal events, risk, jaw fracture, OPD, stroke, if CHF, CAD, CVA, you name it. These are common, multiple morbidities. Yes, you've seen diabetes, which is, and maybe congestive heart failure in your practice, but they're in early stages, they're still functioning, and they don't need full-time care. Once you need full-time care, there is something major wrong. And the daughters, when they brought them into your practice, say, oh, there's nothing wrong. Mom's just on aspirin. And now I get in the chart, and it's common today to have somebody on 20 medications and 10 multiple morbidities. You take, well, anyway, we won't go into that. It's all, you should know that. You can go to ada.org and get their abbreviations. I'm sure the AMA has their abbreviations. I've got a pharmacology book that gives me all the medical abbreviations. And you need to know those, and you need to talk that way because you don't have time to write everything out. And I'm skipping around, but x-rays are sometimes possible. I use premolar to premolar routinely when I can. Sometimes they can't even open for this. I do a fiber optic transillumination. I just put on my chart FOTI, fiber optic transillumination used, and that substitutes my x-rays. Now, why are dentists so abhorred to this? It's because, one, you don't get paid for it, and in this system, you don't care about the pay, but two, you don't have records if you get sued. Well, your records are what you write down. If they have a small OVD, oral vertical dimension, I may put 1/2 inch, x-rays not possible, that's what you write. Or x-rays could create lifelong TMJ injury, painful TMJ injury, which is very true. Truer than you think. What we do in dentistry on a 40-year-old, you can't do on an 80-year-old. You can't expect comprehensive dentistry. You are now a public health dentistry if you're in this program. And doctors, think of their health first. We're not thinking about what we can do or how much we make or how many people we can see a day. You just do it right, but don't over-treat this age group. It's like I wrote a referral to an oral surgeon, not a specific one, I can't do that, or I don't do that, and said needed number 6 out. Well, they wandered into the general dentist of the social services director, and they went, and I wanted 1 tooth out. He took out 10 teeth and crushed her jaw in the process, and he didn't know his patients. He didn't know his patient. And I know the fragility of all these patients because I've seen it. And yes, a lot's anecdotal, but let me tell you what I've done with AAOM and special care dentistry and Oscar and all these other things is you need to study for your life for evidence-based dentistry. You need to do things that are evidence-based. And there's a theory coming down the road, docs, that Clinpro 5000, Duraflor every 3 months, and ineffective home care can eliminate fillings. And that's what ART and MID and Aduina Kid are all about. And my daughter is a research hygienist at NYU in the Pearl program, and all the stuff coming down that those important groups like that are trying to buffer us from and help us understand how it can change us and change what we do is incredible. But for a nursing home population, my MRs, my SDs, my DSs, my developmentally disabled MRs, it's still written MR in the chart, no longer mental retardation. Those patients, ART is even more important for, but the problem is I can only do it about 1/3 of the time because they swallow, and you can't swallow Clinpro 5000 or these heavy-duty things where 2 teaspoons are fatal. You know, yes, milk helps, but anyway, know your patient, doctor, and know the chart. It takes me 5 minutes to study the chart each time, if not more, while my wife, who's my assistant, starts brushing their teeth to get the plaque off just so I can transilluminate and go for it from there. And it's documenting my patient